Good afternoon and welcome to our webinar, Reducing Readmissions, Inpatient OSA Screening, AI, and the Future of Sleep Navigation. My name is Rachel Bohr and I'm EnsoData's Senior Marketing Director. Massey Arrington is Assistant Vice President for Respiratory, Sleep, and Pulmonary Services at Wellstar Health System. Massey is a multi-degree professional with more than 30 years of managerial and technical experience encompassing strategic corporate planning, direct marketing, promotional campaigns, training, and administration in a high-tech healthcare environment. Massey spent several years volunteering on the AASM's Sleep Technologist and Respiratory Therapist Education Committee, and he currently serves as treasurer for the AAST. He has made important contributions to the field, including leading the development of learning modules for AASM and those wishing to prepare for the CCSH. And with that, I will turn it over to Massey.
Thank you, Rachel, and a special thank you to EnsoData for having me. I'm honored. I hope you enjoy what I have to say. I always like getting together right after lunch and telling my story. So I hope I don't put you to sleep. A little bit about what I hope you get out of this today is I want you to kind of understand the general importance of sleep navigation and on inpatient specifically. I talk a little bit about the CCSH pathway and why I feel, and our team here at Wellstar feels, that this credential is really should be a requirement for any form of sleep navigation. And I also talk briefly a little bit about artificial intelligence and the ecosystem of healthcare and where sleep fits into that. Finally, I wouldn't be doing my MBA proud if I didn't have a little bit of nerd talk and cover some math for those of you interested on how I went about selling this program to my senior leaders and getting them on board. Just a little bit about Wellstar. We have 10 hospitals across all of Georgia. Bulk of them are in the metro Atlanta area, but we do have new partners over in Augusta at Wellstar MCG Health, and of course, LaGrange and Griffin. We have 4 health parks, a total of 10 sleep centers, and of course, with the addition of Wellstar Medical College of Georgia, we now have a medical university as well. You've probably seen other talks about sleep navigation and what a sleep navigator is. I'm gonna try not to be too repetitive. I'm just gonna talk about our journey here at Wellstar. So how we envisioned a sleep navigator and how we built the job description here was the first thing I want to emphasize is that we made it mandatory that they have a CCSH. So all of our sleep navigators at Wellstar have the certification in clinical sleep health, and this molded from being an all-around, and it still is kind of an all-around job, focusing on screening and educating. We used to send them, a lot of them go out, they visit doctors. They have a lot of additional duties that they do, but their main focus now, for me at least, has evolved into almost purely inpatient navigation and education. And the reason we took this approach is that, you know, there's thousands of patients admitted and readmitted into the hospital system every year. And we all know, despite what maybe other reports have said, that poor sleep can exacerbate or has a negative impact on a lot of these other reasons that these patients are admitted. And our approach was again, we didn't want to go just for low-hanging fruit. I've heard about, and whatever you can do to get started is great, but we were very grandiose. Sleep disorders, sleep apnea doesn't really seem to discriminate. And a doctor and I were having a conversation a few weeks ago. We really put it in perspective. When you go into a physician's office, they always check your blood pressure, right? They always check your blood pressure. They don't just check the blood pressure of the overweight individuals. They don't just check the blood pressure of maybe the folks who say they, I don't know, eat a lot of fatty food. They check everybody's blood pressure because blood pressure, high blood pressure, hypertension, low blood pressure, these things don't necessarily discriminate, and you should check it on every patient. We feel that strongly about sleep. Sleep should be discussed with every patient. It is a vital sign. It is just as important as diet, exercise, and it should be part of any screening. So the underlying issue here is that physicians, they're in hospitals to take care of why you're in a hospital, right? The hospitalists, the doctors, they're there because you're in a hospital, you're being admitted for an acute illness. So it's not necessarily easy for them to pause and go, wait a minute, how are you sleeping? And I feel like this is kind of where the sleep navigator role perfectly fit. They are able to do the education and those things and give the patient's physicians that are attending them the information, hey, this is going to be flagged. This patient may have an underlying sleep problem. And just a quick note about the CCSH, originally offered by the BRPT in 2014. Prior to 17, you had to be a clinical sleep educator. That was originally provided in 2012. And at that time, it was the only pathway to become a CCSH. That clinical sleep educator is still offered, but it seems to be a little bit less utilized than the CCSH. Back when I first got mine and they had the first exam, we started seeing them hired by large multi-specialty physician groups, and they were helping primarily with CPAP, PAP therapy patients who had questions or difficulty with the masks to free up MD time to see new patients. We've seen that evolve to coaching and compliance, and in my opinion, the CCSH and coaching and/or sleep navigation is probably the fastest emerging career or advancing career for registered sleep technologists. And I feel like coaching and navigation is going to dominate this field probably within the next 10 years, maybe sooner, given that 42% of you said you were already doing some form of navigation. In another year or two, that number could double. For us, I'm not going to read a screen to you, but the role of the CCSH, we view them as medical specialists focused on sleep who are going to educate, support, and basically help these patients get the care they need, whether that's via a consult with a physician, a sleep specialist, whether that's an attended study or a home sleep apnea test, whatever. But the key is at their core, what these navigators and what I see this role for is to help reduce readmission rates and penalties, improve the overall health and well-being of these patients, and continue this education to the general public of how important sleep is, and maybe reduce some of the length of stay and excessive load that is being placed on the hospitals these days. So pathways, there's 3. Clinical experience for candidates with 1,000 hours and a bachelor's degree or above. There's pathway 2 if you have another healthcare credential and a license or an associate's degree and above. And then there's 3, an active RPSGT who've recertified at least once and who have completed a CCSH STAR designated education program within the past 3 years. So my pathway was 3. There was a lot of other folks who've done the other pathways, but it's important to recognize there is a shortage of registered polysomnographic technologists across the globe. So the CCSH is open for other healthcare professionals. I've seen some RTs go and take the exam. We have some nurses that are taking it, but it is nice that there are several different pathways. And I know to me, this is common sense. To many of you, this is common sense, but why is a sleep navigator needed? Well, originally, there was an article written in 2019, and this is the one that really lit a fire for me. Carolyn Frack, they had a report that suggested 24 million Americans have sleep apnea, but they're not aware of it. And 5 years ago, despite what the overall outcome was of a recent report, the United States Preventative Services Task Force said that earlier screenings could lead to an earlier diagnosis and better quality of life. They did say that there needs to be much more research. I feel that we've been gathering a lot of this data here at Wellstar, but my takeaway is you should screen everybody for sleep apnea, any patient that comes through your doors, right? It impacts everybody. Also, there's numerous disorders that get missed that only an in-center study can really catch. It's not just about sleep apnea. There's other issues out there. There's other sleep disorders that are going to have a negative impact, several of which have been linked to heart disease and heart problems. So I'm very passionate that a sleep navigator, again, going back to the idea that sleep is a vital sign, and these are the people that can do it, and there's still a whole bunch of patients out there in the market that aren't being helped. Frost and Sullivan was commissioned back by the ASM back in 2015, and they published a 25-page report, and I would encourage all of you to read it if you haven't, that studied the dynamics of untreated sleep apnea and the impact it was having on healthcare in the workplace and overall economics in the United States. And it was published in 2016, and it was called Hidden Health Crisis Costing America Billions, Underdiagnosis and Undertreating Obstructive Sleep Apnea, Draining Healthcare System. So excellent read, please go read it. So that sort of drove us to take a look, what is the cost burden of untreated OSA? And I do want to make a caveat. This data, I believe, came out in 2015. I ran the numbers last night just to let you know, it's just under double. So all of these numbers in 2024 dollars are about double what they were in 2015, 1.9 to 2 times the cost. So basically 23, what was that, million people undiagnosed sleep apnea, and there's your cost breakdown, but it's $149.6 billion in 2015 dollars, so almost $300 billion in today dollars is what untreated sleep apnea is costing. Those folks who have their sleep apnea treated, that drops to, in 2015 dollars, 12.4 billion, or just under $25 billion in 2024 dollars. So that average cost per person is a huge difference. So treating the sleep apnea, those patients who have their sleep apnea addressed, their cost and burden on our entire country and society is much, much lower. So if you drill down even further, what we've discovered is that if you have a navigator, and they are, especially if you have navigators in places, we're going on our 4th year, the overall length of stay is reduced, as well as the cost burden on the physicians. It's almost cut in half. And again, I think these were 2014 dollars, so it's probably double. Length of stay is probably still consistent. But you always hear that in hospitals, right? Let's reduce our length of stay. How can we reduce our length of stay? This is one way. Now, the other thing is the expenses. Patients who have their sleep apnea addressed, they don't spend as much. Their cost burden is much lower. So the insurance companies, I know, which is why it shocks me that they still deny so many sleep studies. Having your sleep treated, especially your sleep apnea treated, lowers the overall hospitalization expenses, and it lowers the overall average physician costs. So there's kind of the why from every possible angle. Now, we use the stop bang. I'm sure you know what it is. Score of 3 is standard positive value. We were worried that a 3 or 4 may overburden our process, so we decided to go with a 5, right? Stop bang of 5 has a sensitivity of around 96% and really helps eliminate false positives. Now, that being said, when you have navigation in place, we have physicians who have gotten to the point where they know this patient may have only scored a 4, but I want the navigator to see them anyway, and they can still choose for our sleep navigators to go see them. But that's how we started. Snoring, tired, observed apnea, high blood pressure, BMI, age greater than 50, and is your neck size large? I believe this is an old one because I think they just went with 17 inches now, or 16. It's just one. They don't differentiate between men and women. But a score of 5 or higher is what we decided to track. And if you dive into the research behind the stop bang, you'll see that originally the meta-analysis, there were 17 studies, almost 10,000 patients. And this is where they determined the sensitivity. So stop bang was very, very accurate, about 90% to detect any form of obstructive sleep apnea, 94% accurate for moderate to severe, and 96% for severe sleep apnea, or an estimated AHI greater than 30. And you can go look that data up. Another excellent paper, but it's part of the reason why we chose to go with a stop bang. Other hospitals do other things. I've heard about a modified Berlin questionnaire. Some few folks use an Epworth, but any screening, in my opinion, is better than none. Our system just decided to go with the stop bang. Now, I've been with Wellstar for 8 years, but prior to me coming, I found this data when I was here for the first year. They actually did a study at one of our hospitals, Paulding hospitals. And they did pre-admission. They were looking at pre-admission testing for patients who were scheduled for surgery. And they screened, I think it was over a year, a calendar year, they screened 834 patients. And we found almost 39% at very high risk for untreated sleep apnea. So at that time, they were looking at a stop bang of 4 or higher. And there's our data. But that kind of, when I found that in the reads, like they didn't do anything. They did this study, but then there was no navigation. There was no automatic screening for surgical patients put in place. It was kind of like we did it, and I'm not sure if the director before me, if they published it, but I don't recall seeing a white paper or anything. They put it in a drawer, and when I was going to make my case for sleep navigation, I found it, and I was like, oh, this is good stuff. This tells us a tiny piece of the story. And sort of what that said when I found it was, hey, just with pre-admission testing, there's a significant prevalence of untreated sleep apnea. Now, we had some barriers to get this going, and we looked at that. We tried using a nurse, and we had a nurse, and really they stayed initially a nurse navigator, and they stayed involved with Wellstar cardiology. It was we have a huge cardiology group. And the issue we kind of ran into was that the nurses didn't really have any formal sleep training, very small amount unless we sent them somewhere to learn. But without the CCSH, they were not as effective, I think, as the CCSH is. Also, there were charting issues. Who could have access to a medical record? There were some HIPAA concerns. There were follow-up inconsistencies. Just the process didn't seem to be working. Also, at the time, 14, 15, even when I started 17, there was kind of a lack of buy-in from the nursing leadership. And the biggest concern, of course, was adding another questionnaire to their intake process. Oh, another form, really? I don't want to do another form. So we had some barriers, and we had some hurdles that we needed to get across. Now, this is the current workflow that we use. And this was kind of what we put into place. As diagrams courtesy of one of my sleep navigators, Donnie Brown Hill, put this together. You may have even seen it before because I think it's been published. And she worked with our entire team of navigators, but this kind of explains everything that we do at Wellstar. So essentially, when you get admitted, stop bang questionnaire pops up in Epic in your work list, in the nursing work list, and it'll pop up every 12 hours until it's done. And then once any and every patient is admitted to the hospital, registered nurse or LPN will ask the stop bang. And if that stop bang is a 5 or higher, it gets pushed into a work list for the navigator at that hospital. So every day the navigator gets up, comes to work, says, here's my patients that were admitted overnight or yesterday that I can get to that need me to come educate them about untreated sleep apnea. So the navigator then goes to the inpatients, gives them an Epworth, other sleep questionnaires, sometimes the quality of life. They educate the patient and family members, they assess, and they document all of this in the patient's electronic medical record. And then a progress note is created, and now sort of an update to this is they're actually allowed to pend an order. So they'll prep an order. They'll say, okay, based upon everything I just educated this patient on in this discussion, this patient needs a sleep study or a sleep specialist consult as part of their discharge, a home sleep study maybe, but they get everything ready with all their documentation, and the attending doctor sees that and signs it and takes the appropriate action. And the good news about that is we can actually start the process of authorizations and getting those patients taken care of, sometimes before they're even discharged. Now, this process has some flaws that I'll talk about later, but so far, it's working extraordinarily well. Let me tell you some numbers. So this information is since we started doing it ever, which, and Kelly's probably out there listening to me if I get the date wrong, but I want to say it was around June. Well, we started in 20 because it was right after the pandemic started. We fought for it for a couple of years, but I want to say it was around June of 20. We actually started navigating patients at one small hospital, one of our smaller hospitals in Douglas. Then we grew to navigating 4 different hospitals, and they're all small to medium-sized hospitals, but we do it at 4 hospitals now. And since June of 20, those come, and was staggered. I think we started doing it at another one, but over basically the next 18 months, we went from 1 location to 4. So in that time, since launch, 90,624 total admissions, 14,595 patients had a positive stop bang of 5 or higher, right? So this is just a 5 or higher. I'm sure I would be willing to bet that in our demographic, if that was a 4, that number might double, but that's 14,595 patients that our 4 sleep navigators have seen and visited and educated and created orders for. That has generated 3,406 total consults and studies since we started. And if you take and you look at that the readmission rate that we calculated just on the patients who were screened, our readmission rate is right around 0.7. So that's not people who were tested. The people who were tested, I don't have it for the entire time, but I do have it for the last year, and I'll share it on the next slide. But that's pretty amazing because that's less than 1%. And then if you want to talk finance, that's a direct margin of about $1.35 million. So the one thing that is very hard to calculate, because there's a variety of reasons for readmissions, is the impact we've had on the readmission penalties there's 4 groups, of course, that you get penalized on: COPD, CHF, MI, and stroke. So if they're discharged too soon and readmitted in under 30 days, you don't get any extra money. You don't get paid. It's basically free. So that is something I'd like to calculate because I think it tells our story. But I'll give you some other data on the next slide. I also like this quote. Dr. Bill Mayfield is one of our physicians here at Wellstar, and he was talking about navigation in general, but he feels very strongly that it's the glue that facilitates synchronous care. And when I start talking about the healthcare ecology, you'll understand where that kind of resonates, why it resonates with me. So some other outcomes, there it is, June 11, 2020. When we started Douglas, we added 3 more over 18 months. Between, just looking at February 22 to February of 23, I know that's more than a year ago. There's a little bit of lag with all the data that I have to yank out of Epic to get this, but in that year, we screened 42,000 inpatients. 6,347 had a stop bang of 5 or higher with roughly 15%. 342 out of those 6,300 underwent attended sleep studies. That's 5%. And 1,320 had a sleep consult or a home sleep apnea test. Of the 6,300, so of those that screened positive, not of the people who admitted or wanted to come back for testing or did what the navigator told them to do, 48 were readmitted in that year. That's at about 0.76. But only 4 of the 1,662 that underwent the actual consult and sleep testing and followed the navigator's advice and were able to get treated, only 4 were readmitted. That is Six Sigma level, right? That's less than 0.001 of 1%. So just excellent outcomes. And I like to remind you, and I have the data to support it, the mean and median hospital readmission rate can range between 2.6 and 19% for all causes. So our 0.76% of just for screening, just for asking them about it, is a notable improvement and is statistically relevant. I do, and I know it's probably yelling off the page, it's what about these other patients that didn't do, you know, I think the biggest opportunity that we have moving forward is closing this. They screened positive, but they didn't actually go have their sleep study. How do we close that gap? How do we get even more? But I won't lie, that is still a massive spike in volumes and business over what was already a great, in my opinion, growing program. So creates another issue when you run out of testing beds. So here's some more outcomes. These are a little more just kind of the tertiary benefits of having really good, strong navigation at all of these hospitals. Just to do the math, that's a 72% reduction in readmission from the newly diagnosed OSA patients, those patients that actually got tested. And this has been consistent since 2021. It was a little hard to analyze that first year as one smaller hospital. Some of the other outcomes or benefits of this is our sleep navigators are now in a lot of different subgroups. There's a congestive heart failure task force. They're getting in front of the surgeons who are doing outpatient surgery and making sure that they're engaged. And one day, hopefully soon, any patient that goes in to see a physician, any physician at Wellstar, will have a stop bang done, because it's a vital sign. Anytime you come in, people should be talking about your sleep. Other good things, growth. Can't ignore the finances. We've had 28% total growth year over year for the past 3 years, and that's with 12% growth in attended volume alone. All these folks were like, oh, home testing is going to kill the sleep center. It hasn't killed our sleep center. We're busy as heck. We have 2 new sleep center openings planned within the next 3 fiscal years. The one other challenge I have is we've got another 6 hospitals, and they're talking about it. They see what's going on at these 4 hospitals, and they want sleep navigation. And again, recognition almost national, really, for our 4, sleep navigators: Kelly Gladden, Kieran Noe, Donnie Brown Hill, Kim Bali. I would be remiss if I didn't say their names. Donnie Brown Hill is speaking at the 2024 Philly Sleep Conference, sponsored by InsoData, on March 22nd. All of them have been recognized and appreciated on Sleep Tech Talk, an amazing broadcast that my good friend Robert Miller is associated with, and Emerson. It's awesome because everybody's talking about it. The fact that I came on here today and 42% of you guys are already doing it is amazing. Now I'm going to talk a little bit about the finance and math stuff. Check my time real quick. How did I justify this? Well, it had to stand on its own, right? So my Wellstar, senior leader said, okay, let's say because sleep navigators are not inexpensive, right? Highly skilled, very well paid. So how do you justify that? Now I know now, after the fact, it's, the growth and everything we're doing, it's amazing, it's insane, they're worth every penny. But how did I sell it beforehand? Basically, I looked at the case mix of each demographic that I wanted a sleep navigator in. I tried to predict, and just so you know, we've grown like 28%. My original prediction was 3%. I said, we're going to get 3% of these patients are going to come in and have sleep testing. And so I said, all right, what's that increase in referrals and studies going to look like? And then I backed out the no-show rate and the patients canceling or denials because of insurance. And then I backed out the cost per study. But in that cost per study, I included their pay. And then I looked at the net and direct margin. Basically, I call it direct, but it's basically net margin after all your expenses have been paid, including the cost of the navigator. These are fake numbers, but this is sort of what it looked like. And I know it looks really crowded and funny. All I was really trying to get to is, and I guess you can't see my pointer, but the direct margin per case over there, third from the right. I wanted to know what that number was, because that's the key number. And I looked at our case mix, each of our hospitals, and said, all right, this area has a lot more Medicare. We don't make money on Medicare studies. And this was just attended. I just looked at attended volume because that was where I thought the biggest opportunity was. If you were just discharged from the hospital, many times that almost immediately got you through you were going to have an attended study approved, especially if you were recently discharged for an MI, a stroke, or CHF. So I did all this. I ran the facility's revenue expense report for each sleep center. I collected, and tried to look, let's back out all the salaries and benefits, all the supplies, everything that we're spending money on, and I got this margin per case. So let's just say in this example here is $964 per attended study is our direct margin. Those salaries and benefits included the cost of the sleep navigator. So then I said, all right, let's say Kelly Gladden's going to increase my volume is by 25 studies over the next 3 months or what have you at this sleep center by navigating. And I said, let's assume there's a 15% cancellation or no-show rate or 85% referral conversion. That would be 21 patients that actually go through with their testing. So that, based upon the model I just created, that in this particular formula would create an additional $20,000 in net direct margin. And that's how I convinced him. I said, look, these folks pay for themselves, regardless of the fact that it's the right thing to do, regardless of the benefits we're going to see in reducing readmission and reducing the strain on our nurses and respiratory therapists. They stand on their own just because they're driving volume. This is what my boss calls it, soft money. That's soft money. You can't put your soft money in there, Massey, but the soft money hits a little harder than people realize. The penalties are dramatic for readmissions. Also, the knowledge across the spectrum, we've got everybody in these hospitals now talks about sleep. Sleep is on their mind. The neuro unit, the stroke unit, the pediatric units, cardiovascular medicine. Unlike ever before, we see a camaraderie and partnership and discussion taking place, all because of these navigators driving that. A couple of things we changed. We try to anyway, test every single stroke patient once they're discharged, if they're still ambulatory. Children at our children's hospital in Augusta, and the children we study, they're encouraged to get sleep tested following tonsillectomies, make sure there's no residual snoring. Other things we've seen over time, now that it's been long enough, is we're starting to see a dramatic reduced length of stay in this patient population, and of course, improved mortality. Now, it's hard to prove that it's all directly because of just this piece, but it has, in my opinion, it's a huge part of it. Do you want to leave enough time for questions? So, changing pace, because I know you don't want to talk about math anymore. I want to talk a little bit about artificial intelligence and how my team and I discussed and what we think the future of sleep navigation is going to look like if AI could be a piece of that. I went back to him and I said, hey, if in a perfect world, there would be CCSHs on every street corner and easy to hire, and they wouldn't cost a lot of money, and every hospital could have a navigator, even the rural ones, and all would be well. But then I wake up. So there is a place for artificial intelligence as a tool in sleep navigation. And it's because of this theory of healthcare being an ecosystem, right? So if you think about healthcare in general, your physician practices, your pharmaceutical companies, insurance companies that don't like to pay us, there's telemedicine, but a lot of people, when they start talking about artificial intelligence, they immediately think about virtual or non-human or faster items. It's a piece. There's e-health and telemedicine are a piece of it. You have government regulations, investors, and of course patients. And my point is, sleep medicine, it's an important part of the health ecosystem. Again, sleep is a vital sign. The other thing that you have to factor in is that technology, I'm sure you guys already know, put your answer here. I was going to ask another question, but new technology, it turns over, evolves, it cycles every 7 months. So every 7 months, the kids are asking for that new iPhone, and you haven't finished paying off the one you got them last year. How do we keep up with this, right? How do we, as a health system, how do we as sleep centers, how do we keep up with this evolution, right? And a lot of people initially got scared that the watches were going to take over, or the smart mattresses, and some of them tried. But at the sleep meeting last year, we all learned that none of them were very effective in really actually doing the work that the bona fide home sleep apnea testing, the FDA approved home sleep apnea tests do, or the benefit of going to see a sleep physician. And another thing is a lot of people, they want data, data, data. Look at all the data I have. And it takes me forever. I mean, think of all the data that we have on these patients. Because we're focused on the stop bang. We're focused on fixing their sleep apnea. But if you think about all the data that's in Epic, we know what these patients' complete medical history is, unless it was a patient that came in through the ER. We know BMI, many of them have been patients of Wellstars forever. We know their job status, marital status, probably can guess at their income, a lot of scary stuff that I don't really think is pertinent. But how does that train AI to assist my navigators in the future? What data is consistent among all these folks, and what's missing? Because data alone, it's worthless without action. Remember the Paulding stuff. Yep, all these people, 40% of them untreated sleep apnea. Y'all should do something about that. We did. Is AI the answer, or is it a catchphrase? A lot of people use it as a catchphrase, but I do think it's a bona fide tool. We just need to identify how it can fit. And I'll finish my presentation today talking about just a few of those ideas. We have hospitals, if you heard me mention, we started navigating at medium-sized, smaller to medium-sized hospitals. But we have really small, a couple of really smaller hospitals in rural areas. And then we have a couple of giant hospitals. And how do we do this? I don't know if you guys are familiar with this area, but Kennestone's gigantic, over 630 beds. One sleep navigator isn't going to cut it. I'm going to have to, if I turn navigation on there, it's going to have to be unit by unit or even floor by floor. Does AI have a part in that? Is there a way we can scan? If we know with all the data we've already collected, is there a way we can look at the charts and go, aha, these are the people that are going to be a 5. These are the people that you might need to see. I feel like we need sleep tracking algorithms. We can start guessing. When we're seeing this on the respiratory side of things, predictive artificial intelligence can actually take a look at ventilator statistics and see who's going to decannulate, who has a high probability of getting a ventilator injury or infection. How does this work with sleep? Navigator alerts that pop up. So maybe I have a navigator that's working at one hospital, but there's an urgent case over in this rural hospital. At least maybe they could pick up the phone. I feel very passionately about the length of stay impact that all of this has. Improving sleep and improving sleep outcomes is reducing length of stay. So let's look at that. I want to know, right? Especially every year that goes by, we have data. How long are these patients staying in the hospital over the span of their life? I also feel like we're getting data already from some of our patients who have telemetry. Can we use any of that data? Can we use artificial intelligence to identify OSA predictability in those cases? And I do like to say AI is not, whenever you think about AI and sleep, it's like, well, it's just automated scoring. I think there's a lot more potential under the hood. And with new technology coming out every 7 months, who knows what the future is going to hold. And finally, I think that where the magic has happened at many of our locations with our sleep navigators is this integration with nursing and the hospitalists and them knowing each other, and the respiratory therapists and the ICU team. Can artificial intelligence help further that interaction and involvement with these team members? Now, patient expectations, they want their cake and they want to eat it too, right? They won't care when they want it, where they want it, how they want it. And again, as much as like I want people, I want more CCSHs, I want more sleep navigators, I want a navigator everywhere. Some locations I think I want to. We don't have infinite cash. We can't afford it. People yell at me all the time, Massey, how come you haven't published this? I don't have the money or the time or the team in place. I'd like to, maybe one day. I got some Epic people looking at it, but none of us are all made of money. None of our systems just roll or print money. And I think AI can help. But at the end of the day, we also can't forget the importance of empathy, human touch, human interaction. And I think that empathy and that passion is been one of the key successes of our sleep navigation program. And with that, I think I'll give it 10 minutes or so for some questions. I think that's my last slide. Thank you, guys. I appreciate you having me. Rachel, I'll open it up for questions.
Thank you, Massey. That's some great stuff, and love all the math and the data and just how you've been able to demonstrate how successful this has been at your health system. It's just fantastic. All right. What other duties do your navigators typically perform besides patient screening?
Oh, that's a great question. Thank you for asking. There's a lot. There's community engagement. Every one of them has gone above and beyond. They're all speaking, I believe, at the Southern Sleep Society meeting. Donnie's going to Philly, but here locally as part of their job duties. And I don't want to say it's a hit list, but we all have those ordering or referring physicians who maybe don't give you everything you need for a sleep study to get authorized. You know, they mean well, but yeah, we used to see it a lot. I don't want to pick on my cardiac docs because they're amazing, but we get these doctors that, like, this person has AFib, they obviously have sleep apnea. AFib does not qualify you for a sleep study. Won't even qualify you for a home study unless you fib. Sorry, pun intended. But we know that AFib has the highest correlation to untreated obstructive sleep apnea. Did the patient tell you that they snored? Yes. Why didn't you put that in the notes? Did you just stop bang? Did you do any Epworth? So they go out and they meet with these physician practices and they educate them. They're also the ones that have developed most of our cheat sheets. Like, we can't steer a physician, but we can say things like, hey, here's all the diagnoses that we typically see, you know, for sleep testing. They go to community events that are local, volunteering at churches and health fairs. They become my business development liaisons and rounding. We all round. It's not just management. Everybody on my team, if I'm driving somewhere and I'm early and I got 10 minutes, and I pass an internal medicine practice or a family medicine, I'm going in. Here's my business card. Here's what we do. Consider Wellstar Sleep. Your patients need it. Sleep's a vital sign. They do that. So it's now, I won't lie, some of our locations have gotten so busy. I have Paulding is a great example. You know, 20, 30, it's not uncommon for them to need to see 20 patients in a day. And if you do the math, it takes probably 25, 30 minutes of education and time for them to go do that. That's an 8.5, 9, 10-hour day. So, but they do. There's slow times as well. So they act as community, you know, as liaisons for our sleep program, as educators for our physicians, and marketing specialists. They do chart review. I'm probably the culprit for that. I'm trying to get ammunition for an appeal or a peer-to-peer for a physician. They'll dig into the chart and find the things that qualify the patients for the appropriate testing. Great question, though.
Okay, let's see, we've got a lot of them coming in now. How would you suggest advocating for a sleep navigator in your lab when keeping your experienced RPSGT CCSH on nights to run sleep studies because it makes more money?
I'm not sure I agree necessarily with that. So RPSGTs running sleep studies do make money. CCSHs, though, screening inpatients also make money. I don't know if I reiterate. I think, what did I go back to my other slide? But we're talking hundreds of attended sleep studies that otherwise would not have been performed and would not have been scheduled if it weren't for the navigators. They don't get 1,000% of the credit because we still have to have the whole team's important. But this piece, we went into the market, we found a need, we found something that was having a detrimental impact on our hospitals. And I went from having to flex techs in 17 and 18 to not having enough and to needing to open more sleep centers in the past year or so. So I'd say they both contribute pretty equally to my entire team of profitability. By having navigation, you're going to end up doing more sleep studies, believe me.
Mm-hmm. What type of software or database system do your navigators use? Like, how are they integrated?
We use Epic, which is the efficiency EMR, and then the sleep software is Somnoware. They hardly ever have to go into Somnoware. We use Epic, and then Epic and Somnoware integrated, but and then they have a bunch of different surveys and educational materials that they either have printed with them or also.
Mm-hmm. How do you streamline diagnosis to treatment? And do you have an owned treatment entity, or is that outside of the operations of this health system?
An owned treatment entity. We don't have a DME company, right? So we don't deal with that. We have tons of DME companies in the market. We have a Wellstar physicians group, medical group, with 13 board certified sleep specialists and other providers that are trained in sleep, PAs that have gone through sleep training. They see the patients in follow-up. So the biggest gap that I'm faced with right now is we have these patients who can't get in for testing fast enough. And we really have to work to identify those super high risk patients that are at risk for getting readmitted in under 30 days, especially. Because of our growth, we have some locations that are booked out a couple of months, which in my opinion is too long to wait. If I just got discharged for an MI, we need to get them in a stat kind of situation, whether that's home testing or get them in as fast as possible. But most of my sleep docs, they're pulmonologists, ENTs, neurologists, they have a base practice for their primary, specialty. And we have to constantly try to make sure that those patients aren't waiting too long to get in to see them and follow up. And I think that's one of our big challenges. I'm trying to think outside of the box. These patients that are at super duper high risk, is there a way I can get them a CPAP or an auto-PAP device until their sleep testing can take place? What can I do to prevent the readmissions? And we're working on that, and that'll be the topic of a separate presentation.
Mm-hmm. All right, let's see here. Trying to see which ones haven't been answered yet. Do your sleep navigators schedule the appointments, Massey?
No.
If they have the order? Okay.
We have a centralized scheduling team, and then I have my own authorization specialists who are trained in sleep and know what to look for, and they work in conjunction with all of our day techs and supervisors for missing data. So central scheduling, they do all the scheduling for all of our procedures.
Okay. Oh, here's a good question. I think you alluded to this. I feel like this comes up. We've done other sleep navigation webinars, and this seems to come up a lot. So maybe you can opine on this a little bit. It's kind of, we see that sleep navigators have yet to be accepted and utilized for the smaller organizations. So do you expect this position to be more accepted as the years go by? And how do we promote this position to be opened and more widely accepted?
That's a great question. And it all comes down to how I was very, very lucky that, granted, I went in there. I remember going into the CNO's office with my medical director and one of my area managers, and we're like, we're going to do this everywhere. We're going to do it tomorrow. And the chief nursing officer was like, hold on. Showed her the white paper. She used to work at Parrish. She's like, no, go do it at one hospital and show me that it works. Show the system how it's working. And we did that. I think it's always going to be a leap, but if you're in a market where your payer mix is really bad, I find it hard to believe that sleep is not profitable, but apparently there are markets, I guess, where it's, if it's 90% Medicaid or your reimbursement is less than your expenses, then this will be a very challenging sell. But if you look at some of the additional duties other than just you have a small hospital, and You can lower the stop bang number to 4, even to 3, according to the paper, and drive the volume. You'll increase your volume at your sleep center that way. But the behavior and the other job duties, as far as business development liaison, being out in the community, knocking on physician doors and getting referrals, all of these things are going to grow that program. So my advice would be to do an accurate pro forma, a realistic one, and then deliver, because they, we probably had 6 months to a year to show them the money, right? And we did, and it was pretty impactful. Had we failed, I don't know that we would be where we are today. But Kelly didn't fail. She was my first navigator out there. And again, I hear this a lot. Now, there's some markets, I won't lie. I gave a talk in the Carolinas, and there was a person, and the navigators weren't paid very well, and the payer mix was 82% Medicare, and it really didn't make a lot of sense. That's where I think the artificial intelligence or some of these tools that may come out that might help, I hate to use the word replace, but enhance or pre-navigate might come in handy.
Okay, so we've got a couple more before we wrap up. Could you bill for the assessment? And if so, what CPT code?
No, we don't bill. They're inpatients. I mean, these are inpatients, right? So that's why we don't do inpatient sleep studies. You never do inpatient sleep studies. I have a lot of people ask me that. Why don't you just do the study while they're in an inpatient? Well, if you're an inpatient, you're in the hospital. I think Krieger and DeMint, they covered this in Principles and Practices of Sleep Medicine. If you're in an inpatient facility, you are in there because you have an acute illness. And that acute illness is always going to either mask or exacerbate your sleep disordered breathing, right? Stop bang looks at your whole life. It's not just right then and there while you're in the hospital. So we always do the sleep testing 3-4 days post-discharge at the soonest, give them a chance to recover and recuperate. But no, there is no charge. We do a $0 charge just so I can track the patients in Epic, who they navigated on, and get some of this extra data. But no, it's not a billable fee. And even if it was, it'd be part of the DRG, and your daily revenue for an inpatient wouldn't go up because at this point in time, because a sleep navigator spent time with them. If you ever find a way to negotiate that with your payers, let me know.
All right. Well, we are almost at the top of the hour, so I want to give a couple instructions before we sign off. First of all, thank you so much for taking the time out of your busy schedules to be with us today. And thank you, Massey, for sharing your presentation and your knowledge and just your wealth of knowledge on this topic. It's really great to see the results that you're seeing at your health system. So if you have any questions, again, please reach out to team at EnzoData. Massey, thank you so much. Once again, I don't know if you have anything more you want to share, any parting thoughts before we let you go.
No, the world needs more CCSH and sleep navigators, but feel free to, if they have questions, reach out to Rachel, pass them on. I'm happy to answer them. And thank you again so much for having me.